All right, whenever you're ready.
Okay, I'm going to just go ahead and go over the information that everybody can see. And I am super excited that the prescriber and the therapist for this patient are able to join me today. So I encourage Dawn and Teresa to please step in if you have anything to add that you feel like I've missed or need some clarification. So basically, we have a female patient, age 29, that we've been working with for about a year. And when we first started with her, she was doing fantastic. I think she came to us with a little over a year of continuous sobriety. In the past 6 to 8 months, we have noticed more frequent lapses with meth and amphetamine, and when she can get it, fentanyl. She's usually honest with us with her lapses. However, it was the last one at the time that I submitted this, but we've had 2 since then that she hadn't told us about prior to. Generally, we would see a lapse of a couple weeks, and then she would get a couple weeks up to a month back on track. And then this pattern has just continued to repeat itself. So we have been discussing as a treatment team the best way to encourage her to get back on track and be consistent with that. And, just trying to determine the best level of support and how do we provide that for her. Also, as an update from the time that I submitted this, she was not compliant with coming to scheduled group. Whenever we did get her to participate, we offered a higher level of support, including daily check-ins. That was not well received, and she has not been compliant with those. So that's kind of where we're at with her. General assessment, she does have quite a bit of childhood trauma. Her whole entire adult life has pretty much been traumatic with very little positive support. She, did have sexual abuse as a child, witnessed domestic violence on the daily, family history of alcohol misuse and dependence and substances. Her addiction started at age 15 when she was prescribed pain pills for dental work. That escalated very quickly to snorting those, and she did report at intake that between 4 people they would snort up to 100 pills per night of pain pills. She continued nasal use until her sinus cavity completely dissolved. She has no septum or palate. And at that point in time, she began IV use, and she continued that for upwards of 5 years. At one point in time, she was homeless, daily IV use, just in a real bad way. She did enter outpatient treatment, MAT treatment in 2018, and that's whenever she first established sustained sobriety. Since then, like I said, she's had several lapses, and they have just continued to get more frequent with us. She does have 2 children that she relinquished rights to avoid termination. She has no contact with those children. She does continue to work. She did, once she established sobriety, she was able to have some gainful employment, and she does continue to have that position. The partner that she is with is a daily user. So we know it's a struggle. We've tried to provide what support we can for her, and still, of course, point out people, places, and things, and how it's going to be very hard for her to sustain any level of sobriety. We have little to no compliance with getting her to do her individual therapy. We bend over backwards to make that possible for her, and schedule, reschedule, provide encouragement for that. We actually, we started doing we'll call it a motivation technique, that if they no-show their therapy, their individual therapy, then they're not eligible for a full week of medication. So they would have to come and do a biweekly check-in. That hasn't been successful with her. She also has a diagnosis of PTSD, major depressive disorder, and generalized anxiety disorder on top of her opioid use disorder. All things considered, she is, relatively healthy. Her most recent drug screen, which this would be 2 recents ago, was positive for fentanyl with a very high level of 36,000 plus with a cutoff of 500. And then she's also positive for the amphetamine and methamphetamine at that time. So we are just looking for some ideas, some motivation on how to address this, and hopefully assist her in getting back on the right track. And Dawn and Teresa, do you guys have anything to add? Or
I don't, Laura. I think that you covered it all very well. Thank you.
I agree. It's pretty much covered and summed up there. Compliance has been a big struggle, obviously.
What's her dosage of Suboxone?
The 8/2 milligram strips, 2 per day.
Okay.
When did her boyfriend get incarcerated or whatever it is?
Oh, yes, I missed that. He is out of jail now. Don't ask me how. I was very hopeful. I think we were all very hopeful that that would be a turning point for her. He does still supposedly is facing like 36 years, but as of now, he's out.
Bond or something. It's you mentioned it's very hard to stay sober. I would say it's more like next to impossible to stay sober. Especially it seems like women, it's harder if men are using. I mean, it's still hard with men for sure too. But it is next to impossible to stay sober if someone's actively using. Is he abusive to her at all, or just kind of?
Oh yeah.
Does she know about like RDVIC options? Is that something you've explored with her?
I'm not sure what you mean with that.
Maybe domestic violence, kind of like shelters that she could go to.
Oh yeah. We've provided her with every resource possible and encouraged her to utilize any of that. We have Hope here. She's been provided with everything we could possibly think of.
It's a mutual domestic violence situation too. We get down into knockdown, drag outs, fist fights between the two of them. Originally, when she first started our program, she was living separately from him after a domestic violence incident. It wasn't until probably November of last year that he started staying with her pretty regularly. And that, of course, is when we saw all the changes in her sobriety. And the fentanyl use is new. It's probably been maybe the last month, 6 weeks now, because we haven't had compliance from her. But that came on new just recently. When she first started having the lapses, it was strictly amphetamine, methamphetamine kind of issues.
Have you tried to get her as an inpatient somewhere since she's so ill?
Absolutely. Yes, that's been offered to her as well. She has zero interest. She gets we've, I think that we've offered everything that we can think of. Of course, yes, please continue to give us feedback in case there's something we haven't thought of. But we also are at the point where when we do offer a higher level of care, she's way less than receptive. I got cussed out at our last group, not cussed out, but cussed at. Yeah.
Why does she keep coming back? There must be some kind of just medicine, or I mean, she must be getting something out of it, even if she's not super compliant.
That's what we asked her the last time we had her in group was, you know, what was her motivation for wanting to come? You know, what are we doing for her? And her response was that the Suboxone used to help her stay sober, but it doesn't seem to do for her what it did before. At that point, we went into the fact that her behaviors are not supportive of sobriety, and that, you know, and was trying to encourage her to get back on track with talking to her therapist and working on those, the behavioral and the mental and cognitive side of things.
One powerful intervention along those lines is to do a parallel timeline, visual approach to what's going on with her, and to kind of track her substance use and periods of sobriety, and look at how her relationships and her work and her psychiatric health, how all of that relates, you know, to do timelines of each of those things and look at how they're affected by the substance use, and make it more clear in her mind what impacts her sobriety and what her life is like when she's sober.
You know, what do you suspect might have happened 6 to 8 months ago when she started relapsing? Before that, it sounded like she was doing fairly well.
That was the point that she let the boyfriend move in and start staying with her.
Does she acknowledge how bad he is, like that she needs to get away from him, or?
Yes, I brought that up. Our last individual session was really, really good, and I was hopeful that it was going to be kind of the turning point. She recognizes how toxic he is. She recognizes that she is facing a future of staying with him if he's going to be in prison for 30 plus years. And her exact words to me were, I don't have to be alone if he's there. And so we talked about her support system and the friends that she has. And her group has been, I mean, we have members who stop by her house and knock on her door, try to get her up, try to bring her to group. And they were friends before it started. We're a small community. But, you know, she was kicked out of her parents' home at age 11, and she feels like that was her own fault for being a quote-unquote bad child. She just isn't willing to address in therapy the trauma that she's faced, that she's experienced. She knows he's terrible for her. She just doesn't feel like she has anything or anyone else.
And she acknowledges that as long as she's with him, it's going to be nearly impossible for her to stay sober. And she will tell us that. I don't know. It's hard to do when I'm with him.
Yeah. Is she taking any medicines for PTSD or anxiety or anything like that?
She's on Abilify.
Bad for addiction usually. Abilify causes you to be more impulsive. Gamblers Anonymous hates it, so usually it's not a go-to for depression. What else is she taking?
I think she's on citalopram.
And that's another issue that has been near impossible to get her to be compliant with. We have had two or three appointments set up for her right now so far with a psych, and she misses them. Like, she just doesn't go. I'll remind her the evening of. I'll remind her the day of. They call and remind her. Like, we can't get compliance on almost anything at this point.
Just curious.
Go ahead.
What
does she think she needs? Go ahead, sorry.
No, I was just curious, is she taking her Suboxone? Is she compliant with it? is there any simulated compliance, or is she actually taking it?
She is not taking it as prescribed because it will be that she's been out of it for 3. That was something else we brought up on Thursday when we met with her for group, was because she said she forgot that she had to come and meet with Laura and Teresa, and we were like, well, you ran out of medication. How did you not realize? And so getting her to take a daily dose of it now, I think if she's using the amphetamine, that she's just not remembering.
Now, prior to, she was more compliant, like prior to this past week. This past week, we have went way downhill. But prior to that, she was taking it. I mean, she was consistently testing for it. I can say that. Other than, you know, I don't know like how she's using it without, of course, following her around, which is tempting, but I won't do that because Sunny would have my hide.
No, I just wondered if she actually had bup level, what her norbuprenorphine levels were in her urine. Were
her
those
last
positive?
Her last bup level, because we just started adding that instead of just a confirmation, is it there? We just added that, and she's only came in once since we've added the levels. So I don't have any real feedback on how consistent they are. But we are, like, that is something that you know, we added. We also, our standard ICUP urine drug screen set doesn't include the fentanyl, so I've been adding fentanyl every time we do see her. We screen for, in addition to the standard, we also add the fentanyl and then the bup levels as well. And I think where we're at basically at this point, if we can get her back in, if she comes back in, you know, it's just, where do we go? Do we continue to treat her with Suboxone? You know, we've tried to look at both sides of this. If we do not treat her with Suboxone, we know where it's going to end up. When we look at where she was when she was consistently an IV user, unemployed, she's still better than she was at that point, but we don't want to just settle for where we're at now because it's not good enough. Because, I mean, she's capable of doing better.
What sort of strikes me as you guys talk about is your clear sort of caring about her, like she's kind of won your guys' hearts, which is to her credit, given, you know, the kind of attachment issues she likely has given her trauma. So I think that's a real strength, that she has a connection to you and you have a connection to her. You know, everything you described, she's really a harm reduction patient, and many of us are not set up to do harm reduction, although, you know, can you do some kind of hybrid with her? The problem is always like, how does that impact the group? Because the group actually seems very connected to her also, although if you let someone function at the level she's functioning at in a group setting, sometimes it can have a negative impact on the group, given that she's so non-compliant.
And that's where we're getting right now, is our group is getting very frustrated that she's not coming in, that she's not being compliant, that she's not, and it's not even a matter, I mean, they know she's obviously not getting up and coming to group, but she'll tell them that she didn't come, she'll tell them that she got her medicine anyway. It's just been kind of a crazy situation.
Yeah, I mean, I don't think anybody has like a super easy answer, given her history and given her struggle and the fact that she's, who knows what what impact he has on her, just in terms of whether she's taking it, whether she can take it. Sometimes maybe she can, maybe she can't, what he's telling her. So as long, I mean, I think this has been said earlier, like as long as he's in the picture, her ability to be well is really limited. So, I mean, she needs a daily dosing, but she's not going to come for daily dosing, right? And so, I mean, I do think once you see her having a negative impact on the group, you kind of have to pull her out of group to preserve that. And then the question is, what are you willing to continue to treat her kind of on an individual basis, more from a harm reduction perspective, to keep her alive long enough for him to go back to jail, or something, you know, something to change in her environment to support recovery.
Sometimes it requires hitting rock bottom, you know, to have a bottom where she just can't tolerate that life anymore and something has to change.
David, I think I keep seeing you unmute.
Yeah. The other question, yeah, what does she want? Because I mean, I agree with Laura completely. I think having her in group is probably very detrimental to group. And so we've had a few people like this where we basically say, we'll see you individually, but these are the conditions. Initially, it'll be weekly. And if they're still not doing well with that, up to what Laura said, even daily. But I think it's what's going to motivate her and what does she need? Because I would worry if she's using, you know, basically we're seeing a lot of that mixture of amphetamine and fentanyl together, which they call scramble caps around here. Is she even taking her Suboxone, and is she selling it? Because we were seeing a lot of that too in our patients that are, you know, not following through. And so then I would look at your ratios of your norbuprenorphine to your buprenorphine levels, and that may help you, because that means that she's really just taking the medication and not ready to be in treatment at this point. And you know, you're not even doing harm reduction at that point, you know.
Thank you.
Thank you so much. In the interest of time, does anybody else have a comment or question?
I just wanted to comment as the internist on the case that I think the citalopram is particularly dangerous if there's meth relapses, because they're both the citalopram and the methamphetamine prolong QT. And it might be worth adjusting that, even though you may be afraid to mess with something that's worked.
Okay. Thank you so much, Laura. That was a great case. And thank you for submitting the case. I encourage everyone to keep doing so. You guys are an excellent group.
Hey,
All
I
right.
just have one more quick thing to add, if I can. I'm sorry. Just for some clarification, I brought this up a couple weeks ago. I know Dr. Berry was on here at that point. Is there any change, or are you guys aware that, like, if any doctor can prescribe Suboxone for up to 30 patients at this point, and you only have to be X-waivered to prescribe for up to 100? Has there been any change with that, or?
No, it's still, don't mess with that. That was a weird thing, because the DEA is the ones that say if we can prescribe it or not. So it was like Health and Human Resources that was trying to like do away with the X waiver, but they didn't have, the idea is they didn't have the jurisdiction to do it.
Okay.
So it was never a thing. So I would never encourage anybody to do it.
Okay. That's what we thought. And then we had some feedback that was a little bit different here recently.
Yeah, no, I wouldn't mess with it anyway. I mean, there's always the 72-hour rule if someone's in the hospital and a non-waivered person can prescribe it, but don't mess with it unless they have otherwise.
That's a very good question, because I've seen a lot of the opposite out there, with good intention, of course, but the timing of the release of that information via the guidelines from like DHS or whatever Dr. Houston was saying there, you know, like a lot of people are out there. I've seen it on LinkedIn a lot of like, oh yeah, hey, it can be done. And it's like, no. I had to roll back a couple colleagues on the same idea of like, actually, no, I don't want to get political, but it's not. So, it was a close one though.
Thank you so much. Perfect. All right. Mark, when you're ready, go ahead, and I've given you co-host capabilities, so you can go ahead and present your didactic.
Alrighty, let me click some buttons here. There we go. And all right, I think we should be on big screen, and then you can probably see my mug and maybe 3 other people. All right, so here's the deal. Coming after that case, Laura, Teresa, and Don, you 3 and your whole team, quite frankly, are just doing so amazing. I believe, as other Laura was saying, of just the care that you're putting in. Yeah, you know, as the pharmacist, well, what do you need more dosage of there? I think you're already ceiling effect to your care, but keep it going. you know, that's where we are. So after a case like that, it's I wanted to make this a little light, not knowing what was going before me. So just remember there is compassion in this guy. But you know, best of times, worst of times, Mr. Dickens, it is probably apropos as the three clinicians were talking about transitioning that patient to a little bit more intense urine drug testing and looking for specifics there and whatnot. So perhaps it is right after this. If there's a background noise that annoys anybody, please let me know. I usually always turn my office fish tank filter off, but I figure with a title like this, what's the worst that's going to happen? I mean, you might have to visit the restroom afterwards. Anyways, so today we're going to go over urine drug monitoring. I don't know how. I have done lots of talks on urine. A group like this, I'm sure 90, if not 100% or more abreast on all of the intricacies, clinically speaking, when it comes to urine drug monitoring. But that's not the case universally, and I know you know that too. Outside of my practice of any clinical care, even being in charge of the final year of our school of pharmacy, there's a lot of requirements for students, professional students, to go to sites, and it's amazing in talking with testing or screening sites, the language that they use, that they think they're doing testing, and it's like, no. So then even our schools, like or our employments, you know, it goes everywhere. So, all right, we're going to go over a lot of urine drug screening and testing here today. What are we actually doing though? So those of you that know me, you might not even know, but I'm a huge baseball fan, me and my family actually. So this is the Cubs. I believe it's actually when they're about to win one of the World Series, like first time in a century. But what the heck am I showing that for other than being a baseball fan? I got a feeling you might know. Check out that guy. What's he doing? There's a gentleman in there, I don't know who it is, sorry, that just hit a home run or scored, and the umpire's job is to trust that he just probably won a World Series, but verify that his foot hit the plate. Foot doesn't hit the plate, you're out of here. We're not going to take that line into clinical practice necessarily, but another little way of thinking about what are we doing here? You know, it's not that we're not trusting. There's things like adherence that we worry about as well too. But we're verifying things along the way. Really big picture, better for another audience, but there's urine drug monitoring, that's the umbrella. Then you have screening and testing, obviously cheaper little cup relatively, compared to the big, you know, $50,000 HPLC chromatography machines and whatnot. I actually got to work with one of those things when I was an undergrad. I don't really know how that worked out, but I remember being scared, thinking, oh my gosh, if I break this, it'll take me 50 years to pay for it. And here we are now talking about them. But I think a lot of things get sensationalized in our world. One of them is, well, what are we up to with this? And again, you know, not glass half full of whatever here, I guess, today. But we're looking at improving that, looking for adherence as well. Just like came up in the case today of, you know, is the patient utilizing the medicine or not? Or are they selling it? It's a concern we always have to think about. We're not, sadly, not psychic. But it's also about prevention. You know, people, I don't have a slide with or a picture with this one, but people respect what you inspect, not what you expect. So the mere fact that we're inspecting it, we're trusting and verifying, sometimes can get us somewhere. Not all the time, but it can get us there. So, all right, some of the more minute different things here. Of course, the cup, the screening being presumptive, the testing being definitive. You know, it's what holds up in clinic and court. That's in blue here, of course, and the testing, the definitive testing. Certainly is going to take a little bit longer depending on people's settings. I've seen office settings where they can take care of it even within their own compound, their grounds. Most send it off. I know, like for instance, at our pain center, it gets sent off, but then there's no action needed. And I think it's one of the beautiful parts of it all where no one has to go clicking buttons and logging in and figuring out a password and seeing if Russia got it before you. You get notified if something's out of line. And that's, I think, something really important to set up no matter what. I'm sure many of you do have that. With testing, it's obviously, it's the specifics. You're going to be looking more so with metabolites and whatnot, like we were already talking earlier today, so I'm not going to go into detail with that. Obviously, But you never want to skip over this obvious one. There's the difference in price. And that's always going to be such a limitation, no matter where you go. It's amazing that even though, I just put these relative dollar signs at the bottom, but a lot of the pain conferences that I'll go to, it amazes me when you go to the bigger ones, not the regional ones, but the national, international, whatever. When you go to the expo hall, my gosh, have you ever seen so many like sample cups anywhere? like there's times one was in Vegas and it was like, do we get to take them home? I mean, do I take this on my flight? What's PSA going to say here? Or TSA. Anyways, those in Maryland, there was cases where there was a lot of fraud involved, even just with the cups, not the testing. So things to keep in mind. So very basics here, though. What are we dealing with? This isn't rocket science that's going to get us to Mars here. Elon's got nothing to do with this. It's a basic immunoassay, kind of like a pregnancy test. But if you want to get the really big picture here, I go with extremes. A pregnancy test, I mean, when people use 15 of them in the heat of that moment of figuring things out, probably it's going on 5 o'clock now. The dumbest thing you're going to hear today is, oh, one of these immunoassay pregnancy tests that's going to tell you it's a boy. Of course not. You'd be lucky if you get a true positive or a true negative, let alone all the false positives and false negatives in that particular scenario, let alone with urine drug screening. It's never going to tell you, quite frankly, what you're really looking to get. And then there's all the different ones. We had hintings of that. It already came up in the case today too, of the various ones, and then the add-ons. There's always add-ons too. I professionally find it interesting / amazing that most of, when you're talking employment, when you're talking professional schools and whatnot, when we have these mandates for it to be done out there, we go with the lowest bar on this chart. If you guys could think of a better way for me to portray this, just trying to show like all the things that are added on in the larger panels to get a little bit more specificity and additional substances as well too. But you even look at the employment things and you look at the first ones there. It's like, well, what about, isn't fentanyl the biggest thing right now? And it's not even what's looked for in employment technically by this. That's outside of what we're talking about, but it's interesting. I had some encounters with our school of pharmacy of what we were doing as far as kiddos coming in. And it was just ironic that the person that got put in charge of that was yours truly. And I'm like, what are we doing? Like, why are we doing this? It's a complete waste of everyone's time if there's an issue. Hopefully there's never an issue, but so that's more so for reference there or thinking, I guess. But here's one just talking about false positive, false negatives, kind of alluded to with that whole it's a boy pregnancy test there. But what might be a little bit more eye-catching is all the false negatives. I'll eventually go over some more false positives, but we're looking at, it's almost like placebo effect here. Like a third of the time, it might not even tell you when it's there. And yes, there's specifics with cutoffs and all that kind of stuff, but this is just on the surface. And it's, you're getting what you're paying for, basically. So people usually love this one for whatever reason. Maybe it's just my pharmacy folks. I don't know. Alicia, I know you're out there. I think that's it for us today, but no, absolutely no reason to memorize. No, we're not in a big hall today. Normally I'd say, put the iPads down. You don't need to take a picture of this. 5 more slides will get you there. But these are things that can create that false positive in a cup for the substance that is in the left-hand column. And the reason that I show it here is not for memorization or like, oh, wow, some of those are OTC. Oh my gosh, I could get some of those at the grocery store or the dollar store. It's the fact that we need to ask the questions that we need to ask. So do we forget to say, hey, anything over the counter, any supplements? What are you putting in your body? Anything and everything? Are you sure that's it? Okay, now do the $5 to $10 cup. Because if not, then there are some smart cookies out there. Just because there's no MD, PharmD, PhD, whatever after a name, I see some heads going, you guys know. And it also sometimes becomes a game. You know, don't hate the player, hate the game. I know. But we have to line ourselves up with asking those steadfast questions of, in other words, what is in your body? We need to know. A lot of these things you can acquire and might not remember. Quite frankly, in a patient's life, everybody's busy. You might not remember. So we'll go into some of these later, but no need to memorize again. All right, opioid guy. So this is actually hot off the presses. I wanted to update this a couple of weeks ago. We're going to make MedChem fun, not fun again. But structural classes of opioids, how I would put them here. Very, very specific to the idea there. Why is this even relevant in this room? I'm sure pretty much everybody knows, because you're looking at those immunoassays, especially, but everything. The immunoassays are looking for structural similarities. So over half, maybe 2/3 of drug overdose deaths now are fentanyl. That's over in your phenylpiperidines towards the right here. Yet we're screening for towards the left. Interesting. Now, like the case said earlier, I did a lot of folks here in our little bubble. That's not the case. That's not what we're doing. But outside of the bubble, when you add more zeros to the audience, the hundreds of thousands of us everywhere, that is what's happening. And is it the most strategic thing? But the big picture here, though, is that it's always about the structures. It's making MedChem fun somehow, or at least necessary. Most of us don't appreciate those undergrad courses, present self included, quite frankly, but this is where they become real. All right, what's it been, like 10 minutes? I'm still talking about urine. I can go on, and then I will, because, well, Elizabeth told me to. I don't know if you guys would agree. But let's keep you awake. All right, so I take some heat for part of this slide, so I made part of it smaller, just to whatever. But these are ways that people try and debunk the old urine drug monitoring, screening technically. Home remedies. Some of these things, I've had patients come into a pharmacy, this would be years ago, on a Saturday night saying, hey, do you have any of that, the 420 supplement? Young buckaroo, fresh out of professional school, stuck working Saturday night. I'm sorry, but I don't even know what you mean. You know, Golden Seal. Come on, man, keep up. Like, oh, time for me to learn, and we do. I don't think we have the time here today, but there's the whole Golden Seal myth and all that kind of stuff. And then you could just you could buy urine. You could also make your own. I provided some recipes for you. There we go, folks. Your summer's going to be so much better. Or there's the idea, oh, well, if you just dilute it, then it won't come up. But then, oh, well, don't they test for there's the chemical variants and all that kind of stuff. But, you know, this is what a lot of people could be thinking out there too. The whole using someone else's urine. Oh my gosh. So this whole Whizzinator thing at the bottom, I know it gets grotesque, but we also need to have been exposed to this too. I usually get the clinicians that are like, oh my gosh, what are you talking about? Or the other ones are like, I didn't know about that. Ooh. Well then, witnessing a urine drug screening or whatever, testing even, you got to know what weaponry is out there. Some of these things, as far as the kits, of course, you get the hand warmers that we hopefully don't need anymore because groundhog fill is done and it's getting warmer, but you duct tape that thing to your leg with the bag of urine, and then it's about the right temperature because nobody ever wants to hand in cold urine, right? These are all the things that are, well, not most of the things that are out there, and there'll always be new ones. So, but big picture, I just call them conversation starters. That's the cup. Conversation leaders, you know, walking everything results to a patient discussion from testing is certainly different. Of note, recently I was talking with even in our town, and they're everywhere, and it's not picking on anybody because they're all the same, but my interaction was with MedExpress recently, and for our professional students, and they were like, yeah, our test, and I'm like, it's not a test, it's a cup. Yeah, it turns out they were right. Well, check out the cup. The cup literally says test on it, not a test, but it's labeled a test. Well, technically, I guess I'm wrong then, right? But whatever. Tomato, tomato, opioid, we can go on forever, right? Just things to think about overall. In case you're listening to my fish tank by now, feel free to tap out if you need to, but let's go over some cases. Okay. These are real deal things that anybody can encounter. And I have a feeling that most of us here are going to be armed, ready, and willing and whatnot. And like a third of you probably memorized that chart I told you not to memorize. But anyways, you got a patient. Patient is utilizing lisinopril, diphenhydramine, and multivitamin. That's it. We're not going 15 deeper. That's it. Do it a 7-panel, screens positive for opiates. Set. Anybody think that we're injecting heroin QID here? What do we got going on? Any guesses? You know, if we go with crickets, it's fine. But anybody want to guess what was going on here? All right, I'll rescue. So first and foremost, what's the first thing we're gonna do? We're gonna run a test. So strategically thinking there, all of a sudden we're running the test anyway. And for many of us here today, this isn't about what we're doing, but this is about having the conversations with colleagues about what they're doing in their practices as well. And you got to factor in the cost. But in the end, if you're going to run the test anyway, well, this one they found out it was diphenhydramine. But what's the deal with that? Other than being on my little chart with references, why? So I've had, I don't want to say numerous people email me, but enough people email me, call me, whatever, be like, how do we figure it? I ran whatever, and the patient said, oh, after we did it, the patient said they were utilizing this. I even had my mother-in-law reached out to me one time too about a quinolone or whatever. She's a pharmacist too, just throwing that out there. And it's very simple. You go to Dr. Google. Now, I don't work in a drug information center, so I can say, go to Dr. Google. It's pretty simple. Look up the structures. So in this case, we have diphenhydramine and morphine. Pretend you are the immunoassay screening. And what are you looking for? I'm going to try and make it easier here. The red is all me. If you're colorblind, I'm sorry. Didn't think of that. These are similarities. This is what an immunoassay cup would be looking for. So again, here's without, and then now you are the cup. Here's what you're looking for. Flag it. Whereas a test would not be doing that. There's relatively enough there. I'm not going to go on the record or YouTube or whatever we're doing here today saying like, oh, it has to be 50% of the structure, it has to be this or it has to be that. But this is the general aspect of it. And the diphenhydramine compared to morphine, if you just flip them, is pretty straightforward in one space there too. You even got the nitrogen hanging out to the side. So that's what anyone can do with relatively any case. If that was put up in anywhere, clinic, court, whatever, you could be like, those are similar structures. So that's why you don't need to memorize that other chart, because you could just Dr. Google it. All right, another patient case. Patient stated that they're not currently utilizing any medications, but is undergoing smoking cessation. Every single U.S. Surgeon General has always said the most important thing we can do as clinicians is to talk about that. But pretty important too, screen positive for amphetamines. What's up? Anybody want to guess? Supper's coming regardless, eventually. All right. So
He's taking Wellbutrin.
oh, look at that. Dr. Gorby, you got that in before I clicked it. Very good. So this case is from outside of our state, actually, even though we have some things in the works. But it's not that it's over the counter, but they were in a state where a pharmacist can prescribe the smoking cessation. So in clinics and whatnot, might not ever really know. There should be documentation, don't get me wrong, but there should be a lot of things in life. It just doesn't always happen. Run the test, relatively no worries. And it turns out that you nailed it. It was ibuprofen. They were basically on bath salts, right? Because bupropion is a cathinone, which is related to bath salts and gravel. Probably one of the reasons that we're looking at that for possible treatment of stimulant use disorder. But that's about 17 echo CEs in the making. So onward we go. All right, one more. Another patient. I'm not in no medicines, of course, because we probably asked among 400 other things like, do you wear a seatbelt? Of course. But they screened positive for THC, delta-9 tetrahydrocannabinol, marijuana. I'm not going to ask what was going on because we're wide open here. But Turns out in this particular case, the patient just likes to garden, and they got a little sore over the weekend, and they forgot that they went to the dollar store, which doesn't ring a bell as a medical center, and they had some ibuprofen. And I'm not going to pull up the screen. I don't think I am anyway. I forget of showing the structural similarities there, but I can say that a lot of these synthetic, a good amount of these synthetic cannabinoids that are out there are actually like cousins of NSAIDs. In fact, what we're learning is some of the mechanisms of action involve prostaglandins when you're talking about weed in any way, shape, form, fashion, or whatever that Big Jim says. So all the hoopla, and you could just grab some ibuprofen. Good golly. Anyways, that's one that could be very common. Real deal situations here too. So, all right, one more for everybody. And let's get this a little bit harder, right? All right, so this patient case, they're being prescribed oxycodone. They screen positive for oxycodone, but the pill count is off. Has anyone ever encountered that? Silly question. Of course. So what are we looking for? Now, I'm not going to insult anyone's intelligence because this already came up in a different medicine in the case, but of course we're looking for metabolites. So doing the test, we're looking for metabolites, and yep, nice try. You took the pill while you're out in the waiting room or in the car, depending on where you're at for COVID, I guess, and there was no metabolites. Very well played. You know how many times that would get by the average clinician? Darn near always, right? Because why? Like, I mean, 1 + 1 doesn't equal 17. So, but here today, I know my audience, my colleagues here, we know this stuff. So, but that would be to some the upper level. There would be many more, but we do have to, respect time here, I guess. So in this case, if you notice, this chart is color coded red, so we're like, something went off. So what do we do? I mean, in that case, like it's great to know what to run, but what do we do? I mean, this is a little bit more verbose. My apologies and whatnot, but in many cases, it's like, well, think about what was said originally. Whether in the pain world, there could be the pain contracts or whatnot. In the general substance use disorder world, anywhere, it's those conversations of talking about it ahead of time. It's like Back to the Future, like having these conversations ahead of time so that when and if it does happen, it's just so much easier. Always remembering that treatment can continue, perhaps just not with controlled substances. Now, how do you do that in SUD? Well, it's a little trickier, right? But universally speaking, well, when are we calling law enforcement? Well, if lives are in danger. I've run pharmacies that you would never want to be in. If you remember back about 8 or 9 years ago, there was a Baltimore riot, and the focal point was the CVS pharmacy. And they were, as it was being burnt down by the rioters, they were also cutting the fire hoses so that you couldn't put it out. Yeah, last time I was in there, I had nothing but like Percocet in my hand. So there's times when you got to take care of safety too. So I also had my life threatened the second I walked in that building, but whatever, worked my 14-hour shift and called it a day. Helped people. We're here. And just keeping that respect level too. What this all screams is emotional intelligence. I don't know. If we haven't read the 15 books on it, I know I need to as well. So I'm not telling anybody else to. I'm not going to be a hypocrite, but we all need to like this. Always got to remember patient abandonment. Like you need me to tell you to document everything. Come on. Any termination letters, you can have all the details here and whatnot. But one of the things like clinical pearl wise or anything would be that it's not always abandonment. Say you do a urine drug testing and it shows that someone's not utilizing the substance. Well, there doesn't need to be an obligation to provide 7 days of something if it's literally not in your system walking in the door. That's just counterintuitive. So random additional thing to keep in mind. But as was exhibited in the case earlier, just keeping that compassion going too, though. And where would we go from here? My wonderful smartwatch is charging, but hey, and if you cross the pond to other continents and they got like $5,000 toilets that already analyze everything for you, or are we heading there? Or these smartwatches, I mean, they can do oxygen. What's the difference between oxygen, glucose, and oxycodone for that matter? They're all chemicals. I don't think it's crazy to say within 10 years that these watches are going to take care of a lot of things for us. But, you know, let's take care of diabetes probably on the way to other things. But perhaps the future is heading that way. And if we position ourselves right within healthcare, we could certainly benefit from it. So this is not recommended. Apparently, I have lawyer friends. But anyways, if anybody has any thoughts, comments, how are we doing on time here? I think we have a couple minutes.
Oh, minutes, you're right.
I still for anyone. You don't have to put me on the spot. We have lots of teammates here. So.
Thank you so much for that, Mark. It was a great presentation with some good laughs in there and stuff I'm learning. I do know for one question, Jennifer Boyd had a question, so I'm just gonna take that over to her for a moment.
I thought I would take advantage of this this presentation. Thank you. I always learn several things when I hear you speak, but I had a question about a urine drug test that I got back recently, and I thought I could just pick your brain. I think it's a question about, well, I don't know if it's a question about metabolites, and I actually think that I know the answer, but we had a patient who came in one day who admitted to relapsing amongst other things on benzos, and he didn't say which benzos. I think he didn't know. It was a big party and he had used a bunch of different substances, and one of those, whatever was handed to him. He came in the following week and he screened positive again for benzos. So I sent it for confirmation, and I told him, you know, your screen is still positive, because the second week he denied. And he said, oh, well, that's from the week before, it's going to be dropping. And I said, well, maybe, we'll see. So I got the confirmation back, and sure enough, I was going to pull it up. One was dropping, I think it was temazepam, and then the other one was oxazepam, and it was going up. And my assumption is, it is going up, it's not dropping, and you used it again. I mean, it seems kind of commonsensical, but is there any circumstance in which a metabolite would go up 2 weeks after use? And I could tell you precisely which ones they were if you give me 1 second.
Anybody, in the meantime, anybody else have any experience? Anything similar like that? Or?
He had nordiazepam, temazepam, and oxazepam, and I'm assuming that one was a metabolite, but I didn't look it up because I knew you were going to be presenting today. So sorry.
Sure, put it on me. Dr. Google, not Garofoli.
No pressure. I could have gone to Dr. Google, but I was lazy.
So the benzos are just an amazing endeavor as far as medications go. You got your like super quick acting ones, and you got your ultra long acting ones. Those longer acting culprits, of course, you're going to see on things like the Beers list and whatnot. But why are they there? And the reason that they're there is because they have so many long acting active metabolites. Sometimes also pharmaceutically available, and sometimes just not. But I made a slide once, and I pull it up if I could remember where it was, but of showing like that cascade. If here, I think I'm in a box. You'd start here and like, okay, active. You know, you got like 5 metabolites that are all active, whereas another benzo would just start here later in the race. So that's why to get to the end of the marathon, that's where the half-life is kind of coming from for its efficacy. It wouldn't. It is counterintuitive that the original, you know, if we're back over here, whatever side I am, if this thing mirrors, that this would continue to grow without being something being poured into that bucket. Now, other things would continue to grow along the way because it's going to keep going bucket to bucket. But the original, if you had the original amount, it might still be metabolized. Mm-hmm. But to have a week apart, I mean, unless it was like, oh, Saturday of one week and Sunday, you know, you're 4 hours apart technically, which I'm sure is not the case, but right. That just wouldn't make sense. There's just more going on there in general, and I know there's more specifics, but you know, we can kind of go general on that one too. So.
Okay, thank you. That's helpful.
No problem.
I had a question. Okay, so you know how sometimes our patients take NyQuil and over-the-counter medicines to sleep and has alcohol inside it, and then you go ahead and look for the ETS inside. If I take 2 teaspoons of NyQuil tonight, right? How much of would you expect me to have the ETS inside my urine, and for how long?
The and Dina, I missed the very first part. You said NyQuil, but what was the other one? I was messing with my volume to get it higher here.
Oh, no, this NyQuil. Like, how long will the alcohol metabolite be there? And do you even expect it to be there with 2 teaspoons of NyQuil?
Good golly. That's such a small amount. Did you say for a urine drug screening or a test? Because
yeah, like when you check
the cutoff is going to be so low relative to the amount that's in there. I just wouldn't expect that. It's now a tougher scenario would be like, well, can you hand on a Bible? Thank you for not putting me there. Because it depends on what the person actually, is it physically possible? Would you expect it? No. That's where that follow-up comes up, of course, of what we do with it and whatnot. Did Dr. Morrison have something to add? I think somebody was saying he was playing.
About a year ago, the ECHO had one of the ladies from WVU's lab present a series of experiments on herself. Actually, how much did she drink to get that ETG to pop? And it was so insightful, and basically, you could not detect an entire glass of wine, and that's why I was not afraid to put my hand on the Bible. And an entire glass of wine 12 hours afterwards from the night before on the morning urine.
Yeah,
So,
I think the only thing I'd be asking is like technically time, and even then it's like, okay, well, the concentration of the alcohol could be off, but I'm like, let's pretend you have moonshine. I believe that's 100% or as close as you can. It's still just not going to, the math isn't going to work out. And thankfully we have those studies that I didn't know about to show us. Thank you.
Thank you.
Thank
All
you
right,
so
well,
much. It is about that time, but if you have any other questions, please feel free to email me. I can reach out to Mark, or if you'd like to reach out to Mark, it's fine. I will be sending out the recap tomorrow, and I only have one announcement. And the next session will be April 12th, and Jeremy Houston will be discussing matching patients to level of care. Thank you so much. I really appreciate everybody's time today for coming in, and have a great evening.
Thanks, guys.